Thank
you. So, good evening, everyone. On behalf of Rajasthan Orthopaedic Surgeons Association, I welcome you all for the another series of webinar in hand surgery. And today's topic is adult brachial plexus injury. We have a galaxy of the faculties, national faculties, and the local ROSA faculties and good panelists. To start the formal proceedings of today's webinar, first I would like to invite the Rajasthan Orthopaedic Surgeons Association President, Dr. Arun Vaishya, to formally start the proceedings. Dr. Arun Vaishya, sir.
Yeah, thank you, Dr. Rahul. First of all, I would like to extend greeting from the ROSA and wish you a happy new year and good evening to all of you. ROSA, in association with Jaipur Hand Surgery Association, is conducting various webinars on hand surgeries. So in continuation of that, this master class surgery, today we are having a topic of brachial plexus injury, its diagnosis and management. And we have with us Dr. Bhandari and Dr. Lad from Mumbai and Dr. Bhandari from Haldwani. And as a national faculty, we also have Madam Patni, who is the president of Jaipur Hand Association. And the state faculty, we have Dr. Khajotiya, Dr. Narender, Saini, Dr. Ram Prakash. And we also have with us our president-elect, Dr. Vinay Goyal, who is from Jaipur. So not taking much of time. And I know these are very difficult injuries to manage. But with your expertise and with your inputs, I think we all will be benefited. So let's start with the webinar. Welcome once again.
Thank you, Vaishya sir. So I think both of our national faculties do not require much of their introduction, but now I would like to hand over mic to our moderator, Dr. Amit Vyas, to formally introduce our faculty and start the proceedings of today's webinar. Over to you, Dr. Amit. Amit, are you there?
Yeah. Good evening, all. I welcome on the behalf of ROSA and Jaipur Hand Surgery Association to all of you for this academic feast. And we have chosen this area of brachial plexus injury because, as we all discussed, that it is going to affect the young adults. And there is a lot of progress in the field of brachial plexus surgery in last few decades. On the one hand, and on the other hand, a lot of medical professional has a lot of doubts that anything can be done for this entity, surgery is useful or not. And there is a lot of patients are suffering from these injuries. And so today we have invited Dr. PS Bhandari sir, who is one of the eminent faculty in India who is doing these type of injuries. And now he is practicing at Haldwani. And he is retired from Air Force Medical Colleges, and he has spent years on the surgery, and he is past president of Brachial Plexus Surgery Group of India and Indian Society of Peripheral Nerve Surgery. And he is also editor of Journal of Peripheral Nerve Surgery. And although he does not need any introduction, and second with us is Dr. Parag Lad. Fortunately, we have done fellowship together at Ganga Hospital. After that, he has trained from the Singapore also. And he is having a lot of experience in brachial plexus and peripheral nerve surgery. So we invited him to share his experience. And with that, we have our faculty, Dr. Purnima Patni Madam. He is teacher and mentor of all of us from the Jaipur. And Dr. Narender Saini, he is the associate professor at SMS Medical College. And he is doing a lot of brachial plexus surgery. with this, Dr. Dinesh Meena from Kota, he's from the hand surgery unit. He's trained from the hand surgery unit and he's doing a lot of hand surgery at the Kota. And Dr. Ram Prakash Lohiya, he's associate professor at Bikaner. So with this, I invite Dr. PS Bhandari sir to start the proceedings of a lecture on adult brachial plexus injuries, diagnosis and management. Sir, please.
Thanks, Amit, for this nice introduction. And my topic is on Hello. Hello.
Yes, sir.
The screen is visible?
No.
Okay.
Earlier it was visible, sir. Yeah.
Now?
Yes.
Now it's visible, sir.
Okay. You please tell me if there is any problem.
Okay, sir.
Sir,
I'm about
please
to
put
start.
in into
You have to-
slideshow mode.
Yeah, it isn't.
It's okay now?
Yes, sir.
Yes, sir.
So, good evening, friends. My talk is on adult brachial plexus injuries, diagnosis and management. It is going to be a little lengthy presentation, but I assure you that I'll make it as simple as possible, though the subject will be new to many of them. And what I am going to show is what is possible in these injuries and how these injuries should be managed. We all are familiar with the anatomy of the brachial plexus. The brachial plexus injuries, unfortunately, most of the individuals, they are young. They are in their late teens or early 20s. And motorcycle remains the main cause of these injuries. More than 90% victims are because of motorcycle accidents. And you know the popularity of the motorbike amongst the youngsters. Now, it is estimated that 4% of all motorcycle and 1% of all motor vehicle accidents, they result into brachial plexus injury. All brachial plexus injuries are not same. Some are partial injuries, some are much more than that, and some are total injuries. So, and the treatment also varies according to the severity of injury. Now, this patient is a partial injury. This patient has got severe injury, total paralysis. And in total paralysis, in 25% cases, we find that patient has got severe deafferentation pain. This is a burning, crushing kind of pain experience in the limb, which usually occurs 2 to 3 weeks after the injury. Patient forgets about the functionality of the limb. He is more worried about the pain. Usual kind of medicines, whether you give pregabalin or you give some painkillers, the patient doesn't have relief. So this remains an area which needs to be addressed. That is how to relieve the deafferentation pain, which we see in severe grades of brachial plexus injury. Not only the functional loss, there is sensory loss also. And total palsy cases, we might encounter the patients who have burned their hands without their knowledge. Especially this happens in the winter months. In the past, there has been a pessimistic attitude in the management of brachial plexus injury. When we see the literature, the first surgical repair of brachial plexus was done on a 16-year-old girl in 1900. The results were poor. During First and Second World War, a large number of brachial plexus injuries and peripheral nerve injuries were encountered, and most of them were due to the missiles. Again, the surgeons, war surgeons, they attempted reconstruction, but the results were poor. And the common dictum was, if the patient has got severe paralysis, if there is an associated vascular injury, please amputate the limb. There is no point doing any kind of reconstruction. This article was published in the Journal of Bone and Joint Surgery in 1961 by Seddon, who is considered to be the father of modern nerve surgery. He attempted many cases of brachial plexus reconstructions, and he got so frustrated. Ultimately, what he has to mention, the results of reconstructive operations have been so disappointing that we believe this type of treatment should be abandoned. So this was the common belief in the 1960s. But in late 1960s, the microsurgery was developing, and then came an era when nerve grafts were introduced by Milesi to bridge the nerve gap, and Narakaj introduced the nerve transfer, and this revolutionized the management of brachial plexus injury. At present, a majority of the patients with brachial plexus injury are being benefited with microsurgical reconstruction. What has brought this change? This change is in the concept. Now we know that these injuries are traction injuries sustained in high velocity accidents, and they are unlikely to recover in just wait and watch policy. So we refer them early to the referral center for the management, rather than wasting time in unnecessary medications and physiotherapy. Number two, improvements in imaging and neurophysical studies. Earlier, the diagnosis of brachial plexus injury was entirely dependent on clinical examination. But today, we have got MRI, we have got electrophysiology, and this can pick up the damage, and patients can early be referred to the treating surgeon. Anesthesia has improved. We can operate, because these surgeries, they require long time, so we can comfortably do the surgery for long hours. We are much more familiar now with the anatomic details of the brachial plexus anatomy and the anatomical variations as well. This helps in the treatment planning. We are incorporating microsurgical techniques. These patients are done under magnification, under operating microscope and loop magnification. We are using the specially designed micro instruments and the micro sutures, and this has also helped in the management of these injuries. And we are using more and more nerve grafting and distal nerve transfer in the management of these injuries. Whenever we get a patient with brachial plexus injury, we have to evaluate the patient clinically and by various investigative methods. Now, this is a partial injury. What we see here, he has got mainly the upper root injuries. His shoulder is not working, elbow is also not flexing, but his hand function is good. And these are the patients who can be very well managed by nerve transfer or by nerve reconstructions. So this is the first type of injury, that is partial injury, C5, C6. Coming to a little more extensive lesion, that is where the C7 is also involved, where the patient has got shoulder problem, elbow problem, but at the same time he cannot extend the wrist and the fingers. And the other spectrum is of total palsy, where entire limb is flail. There is no shoulder, elbow, fingers are flail, and at the same time patient has got severe sensory loss. These are the patients very difficult to manage, and we can till now we can only partially rehabilitate these patients. Whenever we examine a patient with brachial plexus injury, we must look for the Horner sign. Horner sign indicates that there is injury to the cervical sympathetic chain, and especially which are in relation to the C8 and T1 roots. So this is the patient who has got burns because of the insensate limb. Again, when we evaluate the patient, we should try to elicit the tinel sign in the neck. Presence of a strong tinel sign indicates that it is possible some nerve root might be available. This nerve root can be used for the purpose of nerve grafting. Coming to the radiology and imaging, all these patients should be subjected to the X-ray of the cervical spine, X-ray of the chest, and in X-ray of the chest, we should look for the paralysis of the diaphragm. Many times the diaphragm is paralyzed, and this has to be explained to the patient preoperatively. The significance of the paralysis of diaphragm is that at times some surgeons, they use the phrenic nerve for neurotization. This will not be possible in such cases. Unlike the common saying that the phrenic nerve injury occurs only in the severe grades of brachial plexus injury, I am now saying even partial injury patients C5, C6, they present with diaphragmatic palsy. The main investigation which is done in these patients is the MRI myelography. Presence of pseudomeningocele indicates the root avulsions, but the point of caution is all these MRI pictures MRI investigation should be done 4 weeks after the injury. Immediate picture will not show the pseudomeningoceles. So my recommendation is all MRI should be done after 4 to 6 weeks after the injury. Here we see the MRI picture showing the pseudomeningocele almost at all root levels. MRI also shows the distal injury to the plexus, to the cord level. Electrophysiology, that includes NCV and EMG, they also are used for the purpose of diagnosis of the brachial plexus injury, and they are especially useful when the patients have suffered from limb injuries where the steel implants have been used for the fixation of the bones. In such conditions, MRI will not be possible. So until unless we have put the titanium plates. So in such cases, electrophysiology helps in the diagnosis of these lesions. My request to all orthopedic colleagues is that if the patient has got fractures in the limb and they want to be plated, and at the same time when the patient has got brachial plexus injury, please use titanium plates. What should be avoided in brachial plexus injury cases? Because these are the polytrauma victim cases. We should try to avoid unnecessary fixations. Like this patient who had come to me with brachial plexus injury, but he also had suffered fracture of scapula. We know that most of these fracture scapula, they heal on conservative management, but if we do the fixation of these scapular fractures, we lose the access to the nerves which we are going to reconstruct. So if possible, it is better to defer the fixation of the scapular fractures until unless the fractures are of very severe nature. Similarly, one of the important point which I face is the fixation of the clavicle fractures. There are many cases of brachial plexus injuries which have suffered clavicle fracture. If the fracture are not much displaced, it is better to leave them as such rather than doing the plating. The reason is because we have to go again through the same area and it becomes difficult to locate the spinal accessory nerve, which is one of the common donor nerve, and also it is becomes very messy to dissect out the brachial plexus. So if there is not much of wide displacement of the fracture segments, it is better to delay, because most of them, these fractures, they unite, and malunion is not much of problem in clavicle fractures. When to repair these patients? In total paralysis, we should not delay the surgery, because total paralysis patients, they are unlikely to recover. If the patient has got polytrauma, let him come out of the head injury and other limb injuries, and in 2 to 3 months time, we must operate on these patients. But if the patient has only brachial plexus injury, no other injuries, it is better to operate even 4 to 6 weeks after the injury. So earlier the better. We get good results if we intervene early. In partial injuries, we can wait for 3 to 4 months, because these patients have got some potential to recover. Up to 9 months, especially in the partial injuries, we can do nerve repair, but thereafter the motor end plates start getting degenerated, hence the results of nerve surgery will not be good. Now, another aspect of mode of injury is the missile injuries. In missile injuries, when we explore the wound, we might see the nerves are looking in continuity, because here the mechanism is entirely different. It is because of the cavitation, it is because of the shock waves. So nerves looks in continuity. We should not try to do the nerve repair as a primary surgical procedure. We should wait for 2 to 3 months. The nerves which are looking normal at primary exploration might undergo later fibrosis. So if we explore in 2-3 months time, we know which nerve is healthy, which nerve is fibrotic. So the fibrotic segment can be excised and the normal segments can be grafted. So in missile injuries, it is better to wait for at least 2 months. The procedure which are commonly used for the treatment of these injuries are nerve grafting and nerve transfers. Because these are high-speed injuries, neurolysis has got hardly any role in the management of brachial plexus injuries. So this point I would like to highlight, that we should not rely on neurolysis in brachial plexus injuries. According to the type of injuries, according to the type of root involved, we can classify them into various subgroups. Coming to the first, that is C5, C6 injuries, partial injuries. Here the main problem is in the shoulder and in the elbow. So we have to address these two. Patient has got good radial, median and ulnar nerve functions. So here we can borrow some fascicles from the these three nerves to restore the functions at the elbow and the shoulder. Now, these injuries could be divided into two. Number one, whether there is a break in the continuity, that is ruptures, or whether there is root avulsion. If it is a break in continuity, as you can see, C5, C6 roots, here the upper trunk lesion is there, but proximal continuity is maintained. So we can do the anatomical reconstruction by putting the graft. As has been done here, the C5, C6 root have been connected with the nerve graft to the distal targets. But there may be other situation when we find that the nerve roots have been avulsed from the spinal cord, and these are seen as pseudomeningocele. So in such cases, nerve grafting is not feasible. In such cases, we have to do the nerve transfer. The nerve transfer, which are mainly used for the shoulders, are spinal accessory nerve to suprascapular and the radial nerve branch to long head of triceps to the antebranch of axillary nerve for the deltoid. For the elbow, we borrow fascicles from ulnar and median nerve, and they are selectively transferred to the biceps and brachialis branches of musculocutaneous nerve. This is the incision which is given for the exploration of the brachial plexus. Through this incision, we dissect out the various components of the brachial plexus. Here we see the spinal accessory nerve just above the clavicle and the suprascapular nerve coming from the upper trunk. So these are in close vicinity. Spinal accessory nerve can be transferred to suprascapular nerve for supraspinatus and infraspinatus reinnervation. So this is the classic anterior dissection, but there are certain problems with this anterior dissection. At times, the suprascapular nerve gets retracted distally, and it is difficult to do a direct anastomosis between the spinal accessory and suprascapular nerve. We might have to put a graft. A graft has got its own problem because the axons have to cross two sides, and at each side there is 20 to 25% loss of axons. So results of nerve grafting are, that's why suboptimal when you do this kind of nerve transfer. The other issue with the anterior transfer is that we denervate the trapezius. Trapezius has got a role to play in the shoulder stabilization and shoulder lifting. So if these are the branches which we have to sacrifice to give good mobilization to the spinal accessory nerve for the suprascapular nerve. To obviate these problems, I prefer posterior approach in spinal accessory to suprascapular nerve transfer. This transfer is performed either in the semi-lateral position or in the prone position. Here we see the suprascapular nerve entering into the suprascapular notch, and here is the spinal accessory nerve running along the middle border of the scapula. The nerve is divided somewhere here and transferred to suprascapular nerve. A patient in the lateral position, this is the incision which is given for the this kind of posterior approach. The merits of posterior approach are we can not only we can prevent the denervation of the trapezius, and we can avoid the nerve grafting to the suprascapular nerve, but at the same time we can identify the distal injuries to suprascapular nerve which sometimes do happen near the suprascapular notch. As we can see here, this is the exposure through the posterior approach through the scapular spine. What we notice that the nerve suprascapular, which was looking healthy proximally, has got injury near the suprascapular notch. So if you do the transfer anteriorly, we will miss this kind of distal injury, and our results will not come up. This kind of distal injuries to the suprascapular nerve are more common with the fracture of the clavicle and the scapula. This is the clavicle which has been fractured. It might impinge upon the suprascapular nerve, sometimes to the even spinal accessory nerve, and cause damage to the two nerves. Here also we see that there is a fracture in the scapula, and here comes this is the natural course of the suprascapular nerve, so it might damage the suprascapular nerve. By doing the posterior transfer, we are doing the nerve anastomosis close to the target muscles, that is supra-infraspinatus. That's why we get better results. At times we encounter extensive adhesions in the supraclavicle triangle. I just mentioned about this fracture clavicle which has been stabilized. Here re-exploration will be very, very difficult. So instead of going anteriorly, we can go through the posterior scapular incision. Now this patient who has got stab injury in the neck, and not only the brachial plexus was injured, but many other vital structures including common carotid artery, vertebral artery, phrenic nerve, and other parts of plexus were also injured. If we enter through the anteriorly, this surgery will be very, very risky. So to avoid this area, we can go to the virgin zone, that is in the posterior part. Again, if the patients come late, then better to operate by posterior approach. Redo cases like this patient who was operated by a surgeon, he did exploration, and ultimately he left the patient with so-called neurolysis. Patient has no improvement after surgery, and he comes and then he undergoes different kind of neurotizations performed posteriorly. So posterior approach, which preserves the innervation of the trapezius, it allows tension-free coaptation, and anastomosis site is unaffected by the neck movements. We have got healthy nerves in a vascularized bed, and also the renervation time is reduced. This approach, that is posterior or dorsal approach in transfer of distal spinal accessory nerve into suprascapular nerve, it was published by my team in the Journal of Hand Surgery American volume, and this is one of the standard approach now in the management of brachial plexus injuries. And we could by histomatrometric analysis, we could prove that there are enough number of axons in the distal part of the spinal accessory nerve to motorize the suprascapular nerve. The other aspect of the posterior approach is that we can do the so-called distal debridement. This is the suprascapular nerve distal part, and what we notice here is there is a neuroma in the distal part of suprascapular nerve. We can carefully isolate the nerve, which is surrounded by thick scar tissue, and we can remove this scar tissue. We can go to the healthy nerve. This section is being just proximal to the suprascapular notch. So here is the nerve which has been separated from this scar tissue. Now we'll take the spinal accessory nerve. This spinal accessory nerve along the middle border of the scapula. The nerve has been divided, and here we can do the coaptation of both the spinal accessory and suprascapular nerve. So this is another advantage of doing the posterior approach. But there are certain disadvantages also this approach, because it requires change of position, additional time is required in surgery, dissection is tedious, there is risk of injury to suprascapular vessels, and we are giving an additional scar to the patient. Till now we have addressed to one portion of shoulder, that is how to rehabilitate the suprainfraspinatus by activation of suprascapular nerve, which produces initial 20, 30 or 40 degree of abduction. For achieving full abduction, we have to activate the axillary nerve, and this is possible by using long hair tricep branch of radial nerve and transferring it to the anterior branch of axillary nerve. This was described very well by Somsek and his team in 2003. In this, through a lateral arm incision, the long hair tricep branch of radial nerve is transferred in the quadrangular space to the anterior branch of axillary nerve. So this is the incision which is given through the lateral arm for the procedure, that is the Somsek transfer. This is the incision. Through this incision, we do the this transfer to the axillary nerve. I have also published my work on this posterior transfer of spinal accessory nerve to suprascapular nerve and transfer of the long hair tricep branch to axillary nerve in upper brachial plexus in the Journal of Hand Surgery American volume. Now, what I noticed with the Somsek transfer, which has gained so much of popularity in deltoid renervation, that sometimes there is a difficulty in defining the plane between the long and lateral head of triceps, especially when the patient have got fractures in the humerus. There is a lot of fibrosis, and we have to we find a lot of difficulty in finding the recipient and donor nerves. So In such cases, I'm using now the teres major approach in long head triceps branch to axillary nerve transfer, and these are the landmark which I use for the teres major approach in long head triceps branch to axillary nerve transfer. This is the marking which is done. So this line indicates approximate location of the teres major, and the nerves are in close relation to this teres major. It gives direct access. It averts unnecessary dissection in the triangular space. It gives easy access to quadrangular space. Operation time is reduced. Smaller incision is required. This I have already submitted this for publication. Now coming to the elbow in partial injuries, the transfers used are transfer of, we borrow the fascicles from the ulnar and median now and transfer it to the biceps and brachialis. Very commonly performed transfer. It was described by Oberlin, and it is very popular, performed on the medial aspect of the arm. It is also known as Oberlin 1 and Oberlin 2 transfer, in which we transfer the ulnar nerve fascicle to biceps, median to brachialis, and it was published in 1994 in the Journal of Hand Surgery by Oberlin and his team, and it is one of the most reliable and most effective nerve transfer in elbow flexion. But what we found out in our practice was that whenever we stimulate during in his article, the Oberlin stressed that we should use the fascicle of the ulnar nerve which supplies the flexor carpi ulnaris, but our experience was little different. What we find was that whatever fascicle we stimulate in the arm level, there is mass movement, there is flexion of the fingers, at the same time there is ulnar deviation of the wrist. Like here we see we have isolated fascicles at arm level in the ulnar nerve. Now 3 fascicles have been isolated in different location. When we stimulate them one by one, what we find, there is some ulnar flexion and finger flexion. Whatever fascicle we stimulate. This is the second fascicle which is being stimulated, but we find the same kind of response with each fascicle. So what we concluded that in fascicle transfer, when we perform the Oberlin kind of procedure, there is no added advantage of nerve stimulator. We should use a fascicle which requires minimal intraflexal dissection, interfascicular dissection, and it should be in close vicinity to the biceps branch. We should use 1 or 2 nerve transfer. There is Oberlin and Oberlin 2. Most of the surgeons, they are comfortable now with doing Oberlin 1 and Oberlin 2 together. Now this is a patient with partial injury C5, C6 and who has been very well rehabilitated with this kind of nerve transfers for the shoulder and elbow, which I just described. These are the results achieved after 2 years. So he can lift very heavy weight in shoulder, elbow have become very strong. Another patient who has got partial injury, shoulder, elbow, functions are not there, but these are the results after the multiple nerve transfer targeted towards the shoulder and the elbow. Another young girl who has got this kind of problem, and what results she gets after multiple nerve transfers. She presented with lack of shoulder abduction, lack of elbow flexion, lack of external rotation of the shoulder, and everything has been fully addressed by nerve transfers. So one can see, the kind of good results the patient can achieve in partial injury if we do surgery well in time. Now coming to the little serious grade of injury where the C7 is also injured. So patient has got flailed shoulder, elbow, wrist and finger extension is also lacking. So for shoulder and elbow, we do similar kind of reconstruction. Only we cannot, because C7 is injured, we cannot use the long head triceps branch. So we have to rely only on the spinal to suprascapular nerve transfer. For elbow, we can go for fascicular nerve transfer. For the wrist, we can use the branch of distal branch of anterosseous nerve which goes to pronator quadratus, and it is selectively transferred to the wrist extensor, that is extensor carpi radialis brevis. So here is the distal part of anterosseous nerve, pronator quadratus is here. Now this anterosseous nerve branch will be transferred to the extensor carpi radialis branch, as can be seen here. So this is mainly for the activation of the wrist, for getting the wrist extension. So this is the 18 months post-op results in its shoulder, elbow, and extension of the wrist. So coming to the global brachial plexus injury, where all the roots are injured. This is one of the gray area in the management of brachial plexus injuries. We are doing many procedures, but still we have not been able to fully rehabilitate these patients. And unfortunately, many of the patients with brachial plexus injury fall into this group. Whenever we explore these patients, we should try to see if any nerve root is intact. If some root is intact, this root should be connected with nerve graft to the distal targets, because like here we find C7, C6, C8, T1, all roots are avulsed, but C5 root was intact, that we ascertained by doing nerve stimulation. So this C5 root has got good number of axons, and they can be transferred to the distal part of the plexus with the nerve grafts. So we should always include intact nerve root for the purpose of nerve transfer. This girl who with total paralysis, we elicited the retinal sign, it was positive. So exploration, we found that C5, C6 roots were intact. So these roots were connected with multiple nerve grafts tunneled under the clavicle to the posterior and the lateral cord. Preoperatively, we can see all the features of total paralysis with no hand function. And this is a 7-year follow-up on that girl from Kerala who has been rehabilitated, and she is pursuing her medical education at the moment. Another patient from Kathmandu who had total paralysis undergoes nerve surgical procedures that includes nerve grafting and nerve transfers, and 4 years after surgery. So all cases of the total palsies are not hopeless. We can do something for these patients. Another patient with total paralysis, and the patients after undergoing nerve reconstruction procedures. Now, in total palsy, when we don't have much donor now, we can borrow the contralateral C7 from the opposite C7 because C7 can be spared. There was a lot of enthusiasm about this procedure some time back, but I also used to do a lot of C7 earlier, but now I find that the results of C7 are not always good, and these days I perform C7 only when the patient comes within 2 months of injury, number one. Number two, when the patient is under 20 years of age. So the contralateral C7 is tunneled subcutaneously. It is connected with the ulnar nerve graft, and the usual targets are the median nerve, suprascapular nerve, musculocutaneous nerve, radial nerve. Results are better in the young age, but not in more than 20 years of age, especially when they have come after 4 or 5 months of injury. Recently, Wang et al. They have published their work in which they transfer the contralateral C7 and directly connect it to the lower trunk on the injured side. But there is too much of morbidity involved with this procedure, and few surgeons are going for this extensive surgery. Here is a patient who had total brachial plexus injury. Apart from other procedures, he underwent contralateral C7 to medial cord. So with this, he could achieve hook grip. The other donor which is used in total paralysis is intercostal nerve. And intercostal nerve is mainly used for the musculocutaneous nerve. We generally use 3 intercostal nerve, 3rd, 4th, and 5th, and these are transferred to musculocutaneous nerve for the elbow. So here is a patient with obstetric brachial plexus palsy. The incision in the medial arm, musculocutaneous nerve is not working. So we harvest the 3 intercostal nerves from the chest. The intercostal nerves are mixed nerves, very thin nerves. One should use minimum cautery, and they run just over the pleura. One has to be very, very careful, otherwise one will breach into the pleura. So this is how the intercostal nerves are harvested from the ribs, from under the ribs. Now intercostal nerves are very thin, and even three intercostal nerves are not sufficient to match the size of musculocutaneous nerve. And if we put even 10 microsuture, it becomes big for the intercostal nerve. So for that, I have described this splint and well technique, in which the nerves are initially, 3 intercostal nerves are initially, they are glued together, and instead of putting the suture through the nerves tissue, the sutures are passed, 3 sutures, through the fibrin glue and to the musculocutaneous nerve, epineurum of the musculocutaneous nerve. This will be more clear with this video clip. 3 intercostal nerve, they are glued together, and once gluing has been done, the 3 sutures are passed through the glue to the epineurum of the intercostal to the musculocutaneous nerve. The distal part is trimmed and 3 sutures through intercostal through the epineurum of the musculocutaneous nerve. So there is no direct tissue, direct suture through the nerve itself, because the sutures are foreign body and they induced foreign body reaction, foreign body granuloma. So 3 sutures, once we have done the 3 sutures, then we augment this area with the fibrin glue. So we see the alignment of the nerves with the musculocutaneous nerve, and the area is then augmented with the fibrin glue. So this is the technique which I use in intercostal to musculocutaneous nerve transfer, and this I have described as spin and wheel technique. The advantage I have already mentioned to you. This has been published in one of the index journal as a novel technique in fibrin gluing of intercostal nerves, spleen and wheel technique. This technique is useful in the birth palsy. T1 injuries are there where the shoulder elbow functions are normal, but the problem is in the hand. In such cases, we can use the brachioradialis nerve, and this patient usually have Horner sign. The brachioradialis nerve is transferred selectively to the anterior interosseous nerve for the thumb and the fingers. We stimulate the brachioradialis nerve, it is working, so it will be transferred to the anterior interosseous nerve. So with this, the patient achieves function in the thumb and in the fingers. Another aspect of injury where the lower 3 nerves are injured, C7, C8, T1, this patient will have full shoulder abduction, they will have elbow flexion also, but what they lack is hand function. The hand is flail. No flexion, no extension in the fingers. Only he has got some wrist extension. So in these cases, to reanimate the hand, he has got sensory loss also in the ulnar territory. So in these cases, I recommend triple nerve transfer of supinator branch to the post-interosseous nerve for the extensors. These are the 2 supinator branches which are being transferred to post-interosseous nerve. Transfer of brachialis branch to posterior part of median nerve for the finger flexors. And for the sensory innervation of the ulnar nerve, the lateral cutaneous nerve of forearm is transferred to the ulnar sensory nerve. The other aspect of injury is infraclavicular injury. In infraclavicular injuries, the patient usually present with good amount of shoulder abduction, but the problem is in the elbow and distal. So these injuries may be associated with vascular injuries. In such cases, we do this is the kind of incision is given for these patients, and the injury is distal. It is in the at the level of the cord, at the level of the branching level. So we should do the nerve grafting in such cases. Here we see that musculocutaneous nerve is scarred, thin. So we can do the nerve grafting of the musculocutaneous nerve. Here we see the neuroma in the proximal part of musculocutaneous nerve. So this is the patient who had infraclavicular injury, undergoes nerve grafting, and he achieves good function in the shoulder, in the elbow. His triceps function also returns, and these are the results, long-term results in infraclavicular injury. that at time we face a situation when we don't have any donor, like this patient is a total palsy, his spinal axis now is also not available, as can be seen here, and there is no trapezius action. So what to do in such cases? He has got Horner sign, diaphragmatic palsy, so no donors have nerves are available. So in such cases, the spinal axis now can be taken from the contralateral side. It is lengthened with a nerve graft to the injured suprascapular nerve. As can be seen, this is a nerve graft between the contralateral spinal accessory nerve and the injured suprascapular nerve. It is performed in the prone position. The spinal axis now from the opposite side with the nerve graft to the injured suprascapular. So this is the way we can rehabilitate this patient. So he achieves around 20-30 degree of shoulder abduction with this kind of procedure. So this was also published by us in one of the pub index journal, in Journal of Neurosurgery Spine, use of contralateral spinal accessory nerve for ipsilateral suprascapular neurotization in global brachial plexus injury, a new technique. Coming to the another aspect of patients, those who have recovered their shoulder, recovered elbow, but the hand is flail. Without a proper hand function, whatever function we achieved proximally, they are of not much of help to the patient. What should we do in such cases? In such cases, these days, I use the recovered biceps muscle, lengthen it with fascia lata tendon to flexor digitorum profundus and flexor pollicis longus, as can be seen here. This is the fascia lata taken from the thigh. It is tubed. Proximally, it is connected to the biceps and distally to the flexor pollicis longa and flexor digitorum profundus tendons. And at the same time, wrist is arthrodesed and bone graft and a bone block is placed between the second and the first metacarpal bone. So this is the pre-operative picture. He has got elbow and shoulder, but hand is flail. So with this kind of reconstruction, he has got a partially functional hand, which is of use now, as can be seen here. So this is the way we can rehabilitate these kind of patients. Total palsy undergoes reconstruction, shoulder improves, elbow improves, but the hand remains flail. So for this, similar kind of procedure was done. And this is the picture which you see is after complete rehabilitation of this patient. So these are all total palsy patients done in 2-3 stages. Another patient who comes with total palsy, he undergoes suprascapular neurotization, spinal axis nerve, intercostal to musculocutaneous, and then 2.5 years later, he undergoes this fascia lata transfer to from biceps to flexor pollicis longus and flexor digitorum profundus, and arthrodesis of wrist and a bone block between the first and second metacarpal. This is our team, and here I am with my patients. Ladies and gentlemen, just some time back, there was a time when books used to mention about the amputation as one of the method of surgery in brachial plexus injury, but gone are the days. Now, with microsurgical reconstruction, many of these patients can be rehabilitated very well. Those especially who are having partial injuries, they can go back to their original work. Those who are of more severe nature of injury, their life can be made better, but only we have to act in time. We have to do the procedure under magnification using microsurgical techniques, and the use of distal nerve transfers has really made a lot of difference in the management of these patients. These are certain articles of mine which I have published in various journals in the management of these brachial plexus injuries. At the last, I would like to convey my sincere thanks and gratitude to the Rajasthan Orthopaedic Surgeons Association and the Jaipur Hand Surgery Association, who have given this opportunity to present my work to the August gathering, and I'm very happy that though I might have taken a lot of time, but I think this lecture will give food for thought to those who have got not much of exposure to this field of surgery. Thank you so much. Dr. Patni ma'am, good evening to you.
Good evening, good evening.
Namaste.
Namaskar.
Yeah.
Dr. Amit Vyas, can I ask a question to sir?
Yes, sure.
Yeah, Dr. Parag.
Sir, really wonderful presentation. Even lot of learning point for me also. Sir, may I ask you, what is your approach for clump case brachial plexus injury? Do you give option of exploration, or you straight away give option of distal nerve transfers?
I think in clump case paralysis, because the distances are very long, okay, and it will vary, whether we are talking about the young people or the older people. Older
Okay.
means adult palsies.
Okay.
In clump case paralysis, in the young, we can think of going proximal repair also.
Okay.
That choice we must keep with us. But as far as the adults are concerned, whatever you do proximally, firstly, these patients will not come to you in time. Unfortunately, the patients with clump case, they will come to you after 8-9 months, because everybody gives them the hope that your shoulder is there, your elbow is there, your hand will also come.
Yes.
So they will come very, very late. They will come after 8-9 months, and we don't have any choice. Whatever little we can do, that will be possible by doing distal nerve transfer.
Okay.
Yeah.
Sir, my second question is, if most of the times patient do come with us with MRI, EMG, everything, but for you, which investigation is of importance to you apart from clinical examination?
If you ask me very frankly, if a patient comes with total palsy, okay, of 1 month duration,
Okay.
I don't think that he requires any investigation.
Okay.
But because of, it is very difficult to satisfy the patient.
Yeah.
Today, the patients have got more faith on the radiologist's opinion to the electrophysiology. They will not go for surgery unless they have got some foolproof method.
Yes, sir.
Many times I have seen the results, the electrophysiology and the MRI picture reports are very, very coccoid.
Yeah.
But I have to take this as a pinch of salt.
Yes, sir.
If patient comes 1 month after injury, totally paralytic limb, no sensations, at the same time Horner sign is there, severe deafferentation pain is there, pulse is not there, I should not waste his money on angiography, on MRI, on electrophysiology. He is the candidate for early exploration. But it becomes very difficult in the private setup, especially to convince the patient.
Yeah.
So I always go for MRI, plants and all, then electrophysiology.
Okay, sir. And my last question, sir, if I may ask, what is the last limit of duration to offer a nerve surgery in a 40-year-old, 50-year-old, and 60-year-old brachial plexus injury?
Yeah, you have already specified about the age,
Yes.
The results of surgery depends not only the severity of injury, but also the age of the patient. younger patient, we can increase the length of surgery, the time period of surgery. If the patient comes with partial injury, even 12 months of age also, a young boy, 14, 18 years old, you can think of doing now surgery.
Okay.
But even if a person comes 50 years of age, around 14 months of denervation time, I don't think I should offer him.
Okay.
Same thing might probably I'll be considering in the younger age. It's not good to give them nerve surgery after 10, 11 months.
Okay. Okay.
Yeah.
And how do you counsel a patient for neuropathic pain? And
It
what
becomes-
medical management you offer?
Yeah, it becomes very difficult, and many times the neuropathic becomes the main problem to the patient. They forget about the functional aspect. They don't want that their limb should function. They want to get rid of their problem. Here, I would like to mention that this neuropathic pain, or so-called deafferentation pain of brachial plexus injuries, has not been properly highlighted. These patients suffer like anything. They go into various drugs.
Yes.
We advise them pregabalin, nortriptyline, multivitamins, B complex. I found hardly of any use. I sometimes I keep talking to these patients, keeping them into close confidence. They have
Yeah.
got their own groups where they
Yes.
discuss about their own problems. Cannabis gives the best kick to them.
Yeah. Yes. Sir.
Cannabis gives them the partial relief, but it is very addicting. I do not recommend any patient of this. And the other permanent relief in most of the cases is the dorsal root entry zone coagulation. But as a plastic surgeon, I find myself helpless. I can't do that. I don't have that kind of training. It is done by the neurosurgeons, and it is not a very safe procedure also. And we have got very few. I can count them in fingers who are doing this kind of procedure with high rate of safety. Many patients with who undergo this kind of procedure, they ultimately end up with the lower limb problems. So it is not a safe procedure, and even surgeons, they try to avoid these patients. Here I would like to say that we must develop this DREZ procedure. We must train our surgeons how to get the good results, how to be very accurate in coagulating that area, so that the patient doesn't develop lower motor neuroscience deficits. It's an area needs to be explored, because I keep on getting so many calls from the patient, sir, what to do for this pain? Please tell me. I find myself very helpless. Very helpless. To be very frank with you, I don't have any single referral surgeon in the country to whom I can send these patients who can give them good hope.
Yes,
So
sir.
this needs to be, this area, this has not been addressed. Many of us do not know about the suffering of these boys. This needs to be addressed properly.
Okay. Thank you very much.
This pain is nothing in front of the cancer pain or other type of pain. It is a very severe pain. They don't sleep. They go into drugs at young age. Okay, so this area needs to be properly studied and addressed.
Thank you, sir. Thank you.
Yeah.
Dr. Amit, can I share my screen, or you have some questions?
Other faculty, if they want to ask any questions, if not, then we can proceed.
Is my screen visible?
Yes, doctor.
Yeah. Okay. So thank you, Rajasthan Orthopedic Association, Dr. Amit Vyas and his entire team, and all the senior faculty members in the ROSA for considering me worth talking about this topic, and with my senior Dr. PS Bhandari sir. And it is a pleasure to talk about this topic. I completely agree with Dr. Bhandari sir that many times we don't need any investigation modality to plan out our treatment in brachial plexus injuries. My today's main motto or aim of discussing electrodiagnostic study for all orthopedic surgeon is because we do get bad reports, and we are not able to analyze even a report of carpal tunnel syndrome if we see a EMG. And 90% of the orthopedic surgeons, they land up in reading conclusion of that report, and then we plan, okay, you have panplexopathy or a brachial plexopathy or carpal tunnel syndrome moderate. So in this my 15 minutes of talk, I want to explain the basic terminologies that are being used by neurologist or a technician in EMG nerve conduction study. And we all, irrespective of the quality of report, if we just analyze and if you pick up these words which I'm going to tell you, I think 50% time we should be able to analyze the report on ourselves, as nowadays we are able to analyze MRI of spine, MRI of knee so easily, because we don't depend on those reports. That is my aim to discuss in as a surgeon's perspective about EMG nerve conduction study. I am trained with Dr. Mukund Thatte sir in Bombay Hospital, and there I used to go and meet and see how Dr. Mansukhani madam does EMG nerve conduction study, and she has taught me many things during my fellowship at Bombay Hospital. So this presentation, I owe them a lot to teach me about that. Disclaimer, I have used many times the word EDX. EDX stands for electrodiagnostic study. Please understand that. The content of this is we will learn when to order and when not to order EMG nerve conduction study, how to understand various terminologies, and how to ask for a good quality report. It is like us. We cannot write kindly do EMG nerve conduction study of Mr. XYZ. You have to write probable, just like we fill up a histopathology form, that probable diagnosis, clinical finding, radiology finding, and what exactly you want to see in that report. If you write that, you will get a better quality report. Okay, then how to interpret the report and what are the clinical implications and indications, that is what we are going to learn. This is the basic picture of, we want to see which kind of nerve injuries we are dealing with. Are we dealing with a neuropraxia which is going to recover very soon, or we are going to deal with partial nerve injury or a complete nerve injury which requires a surgical intervention? So our EMG report, if we know this basic microanatomy of a nerve fascicle, then our report is also very easy to understand. The functional unit of the nerve is axons. So it all depends on number of viable axons in the nerve fascicle that will tell us, and that is recorded on a nerve conduction study. And if number of axons are large or if they are increasing in number, that means the nerve is recovering. So with this background, I am very sure all orthopedic surgeons are well versed with this classification. So we will go now to electrophysiology and nerve conduction study. So these are the core areas where this EMG nerve conduction study localizes the pathology. Whether the pathology is directly into the spinal cord or anterior horn cell, we can diagnose pre and post ganglionic route. And if there is a median or along the peripheral nerve, if there is a lesion, if there is a lesion at neuromuscular junction, or the lesion is ideally in the muscle. So these are the locations where EMG is helpful. Now, when to order EMG nerve conduction study? Now, last 2 years, I am very happy to say that many of the orthopedic surgeons, even neurologists, they have understood that there is no point in doing EMG nerve conduction study within 1 week. Okay, so initially we used to see that sometimes also I see that within 3-4 days of injury, people do EMG nerve conduction, especially humerus fracture with radial nerve palsy or a post-injection radial nerve palsy. With 4-5 days also they do EMG nerve conduction study, but it is useless value. We have to distinguish between whether it is a recovering radial nerve, recovering peripheral nerve injury, or it's a complete or partial rupture. So we must understand that neuropraxia injury, anyways, it recovers in 6 to 8 weeks. And other types of injury usually do not even show any signs of recovery in first 6 weeks. So ideally, this is the basic thumb rule that we should follow, that at least wait for 4 to 6 weeks, at least. So why we do that? Because the degeneration after any nerve injury usually sets in within first 4 weeks. And after 4 weeks, with whatever deficit remains, it probably is going to remain permanent, or it will last longer. So that's why it should not happen that if you do the EMG nerve conduction study within 2 weeks and they report complete denervation of a muscle, and you take a call to do the surgery, and when you open the nerve you find intact. Okay, so that's why we should not consider any treatment or any investigation in first 4 weeks of nerve injury. Now, when not to order EMG nerve conduction study and why? Many times we have seen, as I was asking Dr. Bhandari sir, what is the last duration limit to offer a nerve surgery? Why we are talking about we should do the surgery within 10 months, 5 months, 4 months, 6 months? It is the reason is all these we are going to do the surgery on the nerve, we repair the nerve. Ultimately, the axons in the nerve are going to cross the repair site, going to go into the muscle end plate, and then that is going to give us contraction. The muscle will have a contraction. But ideally, the motor end plate, sarcolemma, it's a structure in the muscle. It becomes inactive or it dies or it does not survive after 18 months post-injury. That is the dictum, and it has been proved many times in many literature. Now, if you repair any nerve, it grows or it recovers 1 millimeter per day. Just imagine our surgery is done in the supraclavicular portion of the neck, and we are expecting a hand function or a elbow function where the target is around 300 millimeter, which is 330 centimeters. So 1 millimeter per day is usually 300 days for that muscle to recover. And if you delay this surgery by 8 or 10 months, then the recovery time will be almost double. So it is of no value to consider any study or any nerve surgery after 10 months or 12 months. So this is the reason we should not order any EMG late. So according to this calculation, if you are planning any nerve surgery, then EMG after 1 year is not useful. But there are exceptions to this. And this diagram I want to explain. It is a very simple diagram to explain. So what I want to explain in this diagram is pointer option. Okay, laser. So this is the nerve. It is entering into the muscle structure, and these are the acetylcholine receptors. So what is the the physiology? The axon or the current passes through the axon, reaches the muscle end plates, then acetylcholine mixture, and it adds, and then motor end plates get stimulated because of binding of acetylcholine receptor, and that produces contraction. Just imagine if this end plate, the entire muscle is dead, then there is no point reaching the reinnervation of the nerve there. Exception to study in chronic cases is nerve injuries in children, and when the target muscle of the recovery is expected very nearer. In brachial plexus surgery, there is a transfer called Oberlin Transfer, where we take one fascicle of the ulna in the arm and attach to the biceps. The repair site and the target organ, target muscle is very near. So sometime even at 8 to 10 months post injury, if we repair or if we do this transfer, there is a possibility of getting more than grade 3 power recovery in the bicep function. So this is the second point. And sometimes before considering muscle transfer or a tendon transfer, we may have to analyze. Sometime in brachial plexus injury, the recovery is patchy. We don't know, some muscles will have the more power, some muscles will have less power, and we do have less donor to do the tendon transfer or a muscle transfer. So whether our donor, apart from our clinical examination, if we want to confirm whether the donor muscle or tendon is active or not, we can visualize that, or we can analyze that in the EMG nerve conduction study. Now, what are the terminologies? Please remember, it is very difficult to understand those terminologies in only one lecture. I can share the copy of them. This thing is recorded. You can watch it again and again. So for sensory nerves, we do sensory nerve action potential. For motor nerve study, we do compound motor action potential. Electromyography, these are the three things that we check. Amplitude, that is viability of nerve, conduction velocity, state of myelination, and latency, where the activity is seen in the fastest conducting fibers. Because ultimately the nerve, the nerve fiber should be conducting the impulse or the synapse from one point to another. So you are going to read these points in any EMG nerve conduction study very frequently. CMAP, SNAP, amplitude is delayed, conduction velocity is this much, latency is this much. So how it is applied in the clinical practice, that I will tell you. Then you are going to see these are the terminologies. If you see a term called active denervation, it means it's a recent or ongoing axon loss. This nerve definitely has no recovery chance. It is not yet recovered. If you see chronic denervation, means it's an old axon loss. Then there is an ongoing re-innervation. It means this nerve probably had a neuropraxia injury, or after your nerve repair, first 3 months, when you repeat this study, if you read this name in the EMG report, that means there is a recovery going on, and mature re-innervation is probably a recovered nerve. Okay, and unlikely to matured re-innervation, that is the report where we see more number of axons. EMG nerve conduction study, the graph is more or less like a ECG. I will explain you that. So basically what I discussed is amplitude, where we see this amplitude. The more the height of amplitude is, that means number of functioning axons are good quality. If the absent amplitude, if the amplitudes are very less, then it's an axon loss, it is called denervation. And increase in amplitude, it is called re-innervation. So how do you see amplitude? You have to check both the sides. So EMG is always, nerve conduction study most of the time is always done on both the limbs, because we need to have comparison of, okay, for example, we want to know whether the median nerve is intact or not. The important muscle of median nerves are flexor carpi radialis and abductor pollicis brevis. So what they do, they put a needle into these two muscles and check the amplitude in the muscle, and then find out whether there is a muscle in the muscle, whether there are axon loss, or whether there is a recovering or the amplitude is better. So that is how they test it. Next is conduction velocity. It depends on state of myelination. I will explain that. And distal latency. What is latency? It is a time taken by that stimulus to evade the potential in the fastest conducting nerve. Now let us see the case. Now this is the patient where okay. So this is the patient where this patient had normal shoulder and elbow function. Basically post assault he was admitted in ICU and his hands were tied, and because of the restraints he developed triple nerve palsy in the hand. Okay, and he presented to us 4 months post injury. See, he has radial, ulnar and median nerve palsy. 4 months post injury. There is no history of trauma. Now in such patient, our clinical examination is confirmed. But how do we confirm whether we should offer a surgical intervention or not? So I want to see CMAP amplitude in my recovering nerves, whether my median ulnar nerves are recovering or not. Clinically, sensations are absent in the 3 important nerves, localized tenal sign in the mid-arm. So this clinical examination warrants me to offer a exploration. But then at EMG, clinically, there is a tenal. So how do we confirm? So let us see. So this is the report. Okay. Now what does this report? The left upper figure, median nerve, ulnar nerve and radial nerve, complete axon degenerative. That means there is complete denervation. Okay. And if you see the right lower chart, there are fibrillation 4 plus. Fibrillation means there is a involuntary contractions going on. And if you see the sensory nerve conduction study, where there is no response in all the nerves. So this gives us, I am not putting any conclusion slide here. I am just reading the pages between the nerves. So this gives me option of, surgery, to offer a surgery. So what we found was the intact nerves, but they were having fibrosis. So this is the median nerve which I am touching now. And I did an interfascicular dissection in the median nerve, ulnar nerve, and radial nerve through the middle approach. So that's the ulnar nerve. We did neurolysis, microneurolysis in between the fascicles. And then, in the next slide, this is the early post-operative period. See, the dressing is still not on. At least he has started gaining some control on the dorsiflexion of the wrist. He has started gaining flickering of the FDP function. So this surgery has worked. Now in simple way, EMG will tell us. So if there is a neuropraxia, we have weak muscle but normal motor action potential. If there is axon degeneration, we have to have low or absent CMAP. And in the combined lesion, we have a weak muscle but low CMAP. So this is how the nerve conduction study is done. Now take another example, 26-year-old male. So he had C5, C6, C7 injury with weak hand and wrist flexion. So this is the trapezius function. Okay, abduction is 0, elbow flexion is 0, no rotation possible. So clinically, we have understood that he has extended brachial plexus palsy injury. But now to do a surgery for such patient, we should know whether we can take a nerve fascicle from ulna or median nerve to gain his bicep flexion, which is the procedure in brachial plexus, Oberlin Transfer. But this we are not, because their dilemma is whether it is a T1 hand, whether C8 component is also injured. So what we do in such patient? So prognosis of these patients also depend on quality of, quality and quantity of axon loss, site and complete injury. So now you see the same patients, we have done a EMG. Again, what this EMG, why do you want to see the EMG? Whether we want to know whether his ulnar nerve and median nerve is good or not. So how do we test that? We know we want to see the motor function. So we do CMAP, compound motor action potential. So whether there is a 50%, now see this right side wrist level, the orange color marker, abductor pollicis brevis, the amplitude is 7.9. His affected side is left side. Okay, and here we look at the lower point. The affected side is left. So his median nerve function is very good. Right side is 7.9, left side is 8. So the CMAP is very good. Same way, ulnar 12 and on the affected side it is 11.2. So we can take the fascicle of median and ulnar nerve function in this patient and we can do a Oberlin transfer. The last case that I want to explain is, So this patient who presented to us with the 4 months post brachial plexus injury with C5 C6 involvement, his triceps was recovering. So we were not sure whether to offer a surgery for intercostal nerve to triceps also. So again we did charting for CMAP of the muscles which that we want to test. So the point here I want to highlight, whenever you are ordering a EMG nerve conduction study, you tell the technician or a neurologist which muscle you want to see whether it is live, viable or not. So once you do that, they will put a needle in that particular muscle and they will give you values. So we practically don't need to do look at the conclusion side of the nerve, the report. Okay. So here also, if you are able to see the values clearly, the affected side was left. The APB was 2.92 and here it was 2.7. And same here, FCR was 3.1 and here it is 2.6 and the axillary. So what the conclusion is, if you see the triceps that we want to see, the left side triceps showed no response and the right side tricep showed 1.82 response. So such patient usually they need, triceps is more than 80% affected, then one branch of the axillary nerve is, can be used for the triceps if you want to do the Somsack transfer. But if the response shows no response in one of the muscles, then we should not use that axillary nerve for the transfer. And then he gained the full muscle, the function also. So this is the last case that I want to show, that it's a global brachial plexus injury. The patient had completely flail limb with normal trapezial function and no movement at all, weak trapezius. Again here, rhomboid serratus anterior, they were not working, no Horner sign. But here, what I want to know, whether the serratus anterior is, whether the proximal stump root is available or not. Clinically, yes, there are signs and tests to understand whether the roots are available or not. But if you test EMG of serratus anterior, and if they show fibrillations plus, then we can take a consent for cross C7 or intercostal nerve or other procedures, because we may not find a root in such patients. Now, about the electromyography, it usually records the activities at rest, and it records the activity in voluntary contractions. This is the report. Usually we see in the EMG nerve conduction study, we see whether there are fibrillations or whether there are polyphasics. Means what? Whether there are, motor unit potentials are working or not. So these are the values they usually write. So for accurate for identifying a root lesion, we have, if you want to diagnose whether the patient has preganglionic nerve injury or a post-ganglionic injury, you have to tell them to do EMG of serratus anterior muscle. So if they record some activity there, they will tell you, then we can know there is a root injury or the root is intact or not. For identifying trunk lesion, we have to specifically ask for EMG of infraspinatus muscle. If you want to, so if you want to diagnose about a peripheral nerve lesion, then for median nerve, FCR muscle, for ulnar nerve, FCU muscle, and radial nerve, we should ask for triceps and ECRB. So if you specifically tell the electrophysiologist that what you want to look for, they will give you a report, and you don't need to have a conclusion in reading. So to conclude, I must admit and tell you, electrodiagnostic study is not a substitute for clinical assessment. It is important for medical legal aspect, nowadays insurance aspect. And if you really have, if you order a good quality report, they will give you a good quality report, and you have to tell them what are your clinical findings, so that they will be able to tell you better, what we are looking for in that report. I hope I have clarified some of the thoughts. I am very happy to answer if there are any questions. Thank you so much. I will stop sharing my screen now.
Thank you, Parag, for
Thanks.
Basically, Parag has cleared that prescribing the EMG NCVs should not be just a formality. If it can be correlated with your clinical examination, and it can be extension of your clinical examination. So thank you, Parag.
Okay.
So I have, because we have very less time, so I'll start discussion on the topic. So as Dr. Ram Prakash is there and Dr. Dinesh Meena is there, because you are working at the periphery level. So what difficulty you find with these type of patients, brachial plexus injury, and what are your thoughts? Then we start the case-based discussion. Dr. Ram Prakash.
Hello, good evening, sir. We are facing problems in getting proper assessment of these patients in form of clinical examinations, in form of getting reports with NCVs. And we are not much familiar about, because these are rare cases. So these are the issues.
Means proper clinical examination can be challenged, and proper diagnostic facilities should be there.
Yes.
Madam, could you highlight the what are the problems because you have headed the hand surgery unit. So what are the challenges?
I won't say challenges, but the message that has come out of the two very fantastic talks, messages to our colleagues is number one, not to rush into, firstly, diagnosis. Of course, now we expect everyone to be able to diagnose brachial plexus injuries. But the one most important thing that very frequently seen investigation is an MRI. You see a brachial plexus injury and an immediate MRI is ordered, which, as Dr. Bhandari said, it is not necessary immediately. In fact, a good clinical examination will obviate the use of MRI at all. Then another thing that we see very frequently is associated clavicular fractures with brachial plexus injuries. And time and again, you have seen orthopedic surgeons will rush into fixing the clavicle before the plexus is addressed. So then for a plexus surgeon to go in, he will have to undo the whole procedure. So that is another thing that, and of course, unnecessary electrodiagnostic tests which are conducted without understanding the use and the timing of the tests that are done. In fact, I think we should really leave these tests to the person who is planning the surgery. And another very important thing is counseling. So time and again, we used to have our little hand meets, and we will all remember that it is very useful to have group discussions and have, a number of these brachial plexus injuries together, so that, each patient learns from the other that there is hope. Because most of the times they come to us with, they've been referred by somebody, that there is really no hope. It's a gone case. But when they see other patients improving and how long the recovery, the road to recovery is, then they are a little more heartened. And the neurological pain, which Dr. Bhandari says is a situation which is beyond our handling. I don't know how you people handle it. I don't do brachial plexus surgery. So, but this problem, it's, the patients, yes, they are driven to drugs or even become suicidal sometimes. So this is for our people who are listening. And these are the difficulties that we normally face. So I think you can go ahead with.
Yeah, before going that, because Dr. DS Meena sir is there, he is heading the unit of hand surgery. DS Meena sir, are you here, sir? So I will ask Dr. Narender Saini sir, what is the right perspective of physiotherapy that is usually an advice to a brachial plexus patient? So what are the right perspective? What type of physiotherapy you will advise and at which step?
You see, I think in our whole discussion, we have not covered the therapy part basically. One, what we need to understand is that brachial plexus injuries are usually not an emergency. You need not to rush the patient to a hospital as soon as the emergency, as soon as the injury occurs, unless and until it has a vascular component. So you have to take time. You can send the patient at his own leisure, easily at a period of 1 week, 2 weeks. No problem with that, unless and until there is any severe. Second, before I talk on physio, I would like to answer to Ram Prakash. You see, if you are just talking of examination of brachial plexus, it's generally very, very easy. And I think if you would have heard the presentation of PS Bhandari sir, he has categorized it very simply into upper injuries, 5, 6, 5, 6, 7 and pan plexus. So what you have to look is shoulder is working or not, elbow is working or not, hand is working or not. If you look at these three things, you can identify what the injury is. Unless and until you are treating, identification of this injury and classifying this injury is very, very easy. Third is majority of these patients, as I told you, either they are rushed or they are sent very, very late. And many of the times when they are sent very late, the most commonest thing we observe is that by the time the patient comes to you, he is suffering with the paralytic subluxation of the shoulder. Because no sling has been used, no type of mobilization of the joints has been taught to the patient. And normally the patient will report to you with such a severe contracture of the shoulder that even doing a surgery, even abducting the shoulder for the surgery becomes very, very difficult. So the main message is whenever you are seeing these patients, you treat him or not, the first thing you have to teach him is to do two things. One, use the sling properly and start mobilizing the joints as early as possible with the help of by himself or with somebody else. Now, what basic things has to be done is whatever he can move, he should move by himself. Like suppose you are dealing with the partial palsy where your hand is working. So you can mobilize your hand by yourself, but whatever you are not able to mobilize has to be assisted. Like elbow flexion, do it with the other hand, extension, do it with the other hand. Specifically in the shoulder, doing abduction, external rotation is very, very important because these patients land up into contractures of internal rotation and adduction, which becomes very difficult as far as surgery is concerned. Moreover, once we have operated them, the same applies again because as you would have seen in presentations of PS Bhandari sir, the presentation has shown that the final results are coming or the full functional results are being shown at a period of 18 months, 12 months. So the recovery takes a long time. And if during this period, these joints are not mobilized, these joints are not kept supple, then even a good nerve recovery is not going to give good function. So along with all this, mobilization exercises for the shoulder, elbow and hand are very, very important.
Can I add one point?
Yeah.
Here, Dr. Ram Prakash Lohiya, through your question, I would like to explain to all orthopedic surgeons who are watching this webinar. In a simple nutshell, we have to look at shoulder, elbow, and hand. That is first. Second is, if you see good hand function with no shoulder and elbow function, please be happy because these patients have to be referred to a brachial plexus surgeon ASAP. Because these patients are likely to have best result. That is first point. Second, if you see a patient with zero function from shoulder to hand, please send this patient as early as possible to a brachial plexus surgeon because in a span of 2 to 3 years, they need 2 or 3 operations and we can achieve 50% of the function. That is my second point. And my third point, if patient has good shoulder and elbow function, and no hand function, that is a Klumpke's type of palsy. These are really problematic cases. But again, you have to refer them as early as possible because may not by doing brachial plexus surgery, as Dr. Sir said, if you do a distal nerve transfer where the target organs are nearby, at least some part of the hand function is achieved. So apart from hope, scientifically it has been proved that yes, if they reach in time, good function can be obtained, and such patients need self therapy. They may not need a proper physiotherapy or something. They need to keep the joints supple by doing passive mobilization. Active movements are not at all possible. Sometimes I recommend considering buying a Faraday stimulation muscle machine at home, and we tell them to keep, stimulating the muscles where we want to achieve target. Like we want to have bicep function. Keep stimulating biceps at home. The physiotherapist teaches the patient very well. Okay, and the cost of the machine is 3,000 rupees. It is very, very cheap. So they don't have to go to a therapist every day. They can stimulate the muscle at home once or twice in a day. And well, of course, it has to be trained to them. So this is how, in a nutshell, as an orthopedic surgeon, we can, which patient is going to have good result or bad result or better result.
So it's a very good explanation by Parag. So most of the time, some secondary procedures are required in brachial plexus surgery. So we will come to that discussion. So I'm sharing my screen. So this 25-year-old male who had a motorcycle accident 3 months ago, and he presented for inability to flex elbow and abduct the shoulder. Triceps was good, forearm and hand muscles were good. As Dr. Parag told, this is an happy situation for the any brachial plexus surgeon. So see, he presented me at 3 months. So we did nerve transfers because proximal routes were not available for the grafting. Then this quadruple nerve transfer was done, and then these are the surgical picture. I'm not.
Your slides are not moving. Amit. Put it on slideshow and move the slide.
Okay, sir. Sorry. Is it okay, sir?
Yeah, put it on a slideshow.
Yeah. Is it visible now?
Yeah.
Only first the screen is visible. Put it on the slideshow.
No, it is on slideshow. Is it moving now?
No.
The screen is visible. Screen is visible. Slides are not moving.
Okay.
Is there anyone from OrthoTV? I mean, you have to do the full screen sharing.
Okay, I will do. I think it will work without wasting my time. I think now it is moving.
Yeah.
Yeah.
So this was the case, and for him we have done quadruple nerve transfer, and this is the most happiest situation where we can get near normal function, as Bhandari sir told. But this is another situation. This is 6 months post-op, and he is having, as asked by the Dr. Ram Prakash, he is not having the shoulder, no elbow flexion, and simultaneously there is no wrist and finger extension. So you can say it is 5, 6, and 7 injury, but finger flexions and wrist flexion were good. So initially we did spinal SS3 to supraescapular nerve and Oberlin 2 nerve transfer, and then after 1.5 years he was able to restore the good elbow flexion and shoulder abduction, but there is problem of wrist, thumb, and finger extension. So now wrist has to be reconstructed. So on examination there was grade 5 FCU. Palmaris longus was acting, but FCR was 0. Pronatories has recovered of grade 2, and FDS, FDP, and FPL were grade 5. So I'll ask Dr. DS Meena sir. Oh, probably sir has some network issue. So Dr. Narender Saini sir, could you comment on this?
What is just tell me again?
Basically, this was 5, 6, 7 injury,
Yeah.
and we were discussing about the secondary procedures.
Uh-huh.
So by the initial nerve surgery, we were able to achieve the elbow flexion and shoulder abduction.
Yes, that is fine.
But there is problem of wrist extension and finger extension.
extension.
Yeah. And here is the problem of donor. What I want to highlight that in the usual radial nerve tendon transfer,
here single FCU transfer can be done.
Yes, single FCU. And the second point that although he is having palmaris longus, but it can't be utilized.
Yeah, it can be utilized for thumb.
Yeah, it can be utilized. But we left it for the wrist flexion. Although the finger flexors can overcome the wrist flexion. So I use single FCU for the tendon transfer, and then we were able to achieve the wrist and finger extension. So anyone wants to comment on these cases? Parag Lad or Dr. Bhandari, sir?
No, good choice. Good choice of using a single donor for this thing. So I would like to ask you a question on technical aspect of this transfer. So how do you split your FCU into, you split into 3 parts, right?
No, not 3, 2 parts.
2 parts. So you don't give anything for wrist extension, correct?
No.
Only for EDC and EPL.
Yes.
Yeah.
Okay.
EDC, EI, EPL.
And you expect wrist also to extend because you have done transfer for EDC.
Because
normally
transfer is crossing the.
Yeah. Sorry.
Normally in this, when you are having a force grip of, then you have some wrist flexion.
Achha.
That is the only shortcoming of this. But in these cases, normally, like in brachial plexus, we have very less options of any other transfers. But it works very well in this patient because the functional demands are already low.
Level, correct.
So I have not done the detailed discussion because time is pressing. So I'll ask Dr. Vinay Goyal, sir, to conclude the session and his message for the younger generation. And I will hand over to Dr. Rahul Katta, sir, and Arun Vaishya, sir, for the.
So Dr. Vinay Goyal,
sir. This was a wonderful session, and these surgeries look like magic. And really, there is hope, and more orthopedic surgeons should know about this. Even they don't treat it, but they can send to a proper person at proper time. That is the main thing. So, and I myself knew various new things by this discussion, and I congratulate all the faculty members. And I think these discussions are very good and very useful. Thank you.
Thank you, Dr. Goyal. So today we come to the end of this webinar. It was a very fruitful and wonderful discussions and presentations by Dr. Bhandari and Dr. Parag Lad. We learned a lot about how to diagnose, when to actually ask for different kind of investigation, what is their importance, when to refer the patient, how these patients will go for the surgeries, and a hope should be there. So every orthopedic surgeon cannot be master for the brachial plexus surgery, but at least he must know how to refer these patients, when to refer these patients, what hope can be there in such kind of patients, when to ask for the different investigation modalities, and a proper communication to the patient and the attendants who are really worried. They think it is an emergency situation, their limb will not work. So that communication to the patient and attendants is very important. Today, we have learned a lot many things about brachial plexus, what can be done, what cannot be done. So I think it is a very fruitful discussion. Now I would like to invite Dr. Arun Vaishya, sir, for conclusive remarks. Dr. Arun Vaishya.
Yeah, thank you, Dr. Rahul. I would like to extend my thanks to Dr. Bhandari, Dr. Lad, Dr. Purnima Patni Madam, Narender ji, Ram Prakash, Venegoel, and everybody. Sir, I would like to say that we have definitely enriched by your inputs. Both of you have given us a very good insight of brachial plexus injury. And all those people who have been listening to you from ROSA must have been benefited. And I hope that such webinars would continue in future. And much has been said about it. Nothing much to say. Thank you very much for joining us and giving us the insight about the subject. Thank you so much.
Thank you.
So thank you, sir. So again, in the end, I would like to thank again on behalf of
Thank you
ROSA
so
to our
much.
national faculty, all the faculty members from the ROSA OrthoTV for providing platform. Thank you so much. Stay safe. Bye-bye.
Good
Thank
night.
you.
Good night.
Thank you so much.
Thank you.
Bye-bye.
Good
Good
night.
night. Good
Thank
night.
you, sir. Thank you.
Thank you.
Bhandari, sir.